I think we're alive. Yes, we're live. Yeah.
Yes.
Yes, we are alive. Okay. Hi, everyone. I'm very excited to present our second webinar. Before I start, I wanted to thank my technical support, Edgar. Without his help, I could not do these webinars. Thank you, Edgar. Today, we have a very special guest with us, Dr. Maryanne Makredes Senna. Thanks, Doctor, for accepting my invitation, and particularly your dedication for scarring alopecia. Dr. Maryanne Makredes Senna is a board-certified dermatologist at Beth Israel Health and assistant professor of dermatology at Harvard Medical School. Dr. Senna founded and directs the Lahey Hair Loss Center of Excellence and serves as principal of the research unit. Prior to this role, she founded the MGH Hair Loss Clinic and Clinical Trials Unit, which she ran for nearly 10 years. She has held a number of pharmaceutical device and foundation appointments. Widely published and recognized for her clinical expertise, teaching, and research, Dr. Senna is frequently invited to speak and give lectures nationally and abroad, and has been quoted in top-tier media publications such as the New York Times and The Atlantic. She has also been featured on multiple news outlets, including Good Morning America and in the HBO Max documentary, Not So Pretty. Dr. Senna is an esteemed member of several professional societies and committees and is on the board of directors of the Scarring Alopecia Foundation, the American Hair Research Society, and a medical advisory task force for the National Alopecia Areata Foundation. Well, without further ado, and welcome, Doctor. Stage is yours.
Oh, thank you, Hacho, and thank you for the kind invitation.
You're welcome.
When thinking about what to share with you all today, I often think, patients in the Boston area, I think are pretty lucky because there are a number of doctors who are familiar with LPP and FFA. But as I hear from patients often and have seen, from posts on your webpage that you started, Hacho, which is really exceptional. You should be so proud of the work you've done there to connect people. Not everyone has access to a physician like that. So I thought it might be helpful for me to go through sort of how I approach treating LPP and FFA, how I think about it. And then, of course, happy to take questions afterwards. So I'm going to start by sharing my screen.
Sure.
And can you see this okay?
Yes, everything looks good.
Perfect. I'm going to put it in slideshow view. So we're going to go through the treatment and management of LPP and FFA. Of course, LPP stands for lichen planopilaris. FFA stands for frontal fibrosing alopecia. And both of these I think of sort of as fraternal twins. We are looking under the microscope at a hair follicle of FFA, a hair follicle of LPP. They look nearly identical. But the distribution can be a little bit different. In other words, FFA affects the frontal scalp, largely sometimes ear to ear in the back of the scalp, and the eyebrows, and LPP can sort of affect any other area of the scalp. Some people have overlap. So first, just briefly, alopecia, right, is not a diagnosis. A lot of people confuse it with alopecia areata, which is a form of hair loss. But because I'm Greek, of course, I have to highlight that the word alopecia stems from the Greek word alepou, which means fox. This is an animal that routinely develops common fur or skin condition, a fungal infection called mange that leads to loss of the fur. And that's where the word alopecia has stemmed from over time. And alopecia is just synonymous with hair loss. So it's what is leading to the hair loss, right? That is the diagnosis. Alopecia is just a clinical sign. So hair is unique. And I like to start with this because so many times I see patients feeling guilty, that they feel sad that they have a hair loss condition. And patients will say, well, it's not cancer. Okay, yeah, it's not cancer. And while hair loss is not life-threatening, it's certainly life-altering. And that's something that I think patients should recognize and not feel badly about. It has important implications, hair does, for our self-esteem, our self-image, right? It's a good sign of health. In evolutionary biology, hair is a display of fitness, right? And youth and health. And there really is insufficient acceptance of hair loss as an important medical problem. And I think one of the most profound statistics around this is that 8% of female breast cancer patients, 8% actually think about not treating their breast cancer because they're afraid of losing their hair. And why is that, right? Because when you lose your hair, you lose your eyebrows, you are forced to share what you're going through with the public, with the world, right? If you have diabetes, that of course can be very upsetting and difficult to deal with, but you don't have to share that with the public unless you choose to. Hair loss is not that way. It's very visible, and as a result, carries understandably a very high psychosocial comorbidity for patients. And to add insult to injury, right, while we know that LPP and FFA can absolutely affect men, by and large, 60 to up to 90% of patients with LPP and FFA are women. And when we think about what a beautiful, attractive woman is, right, it's not only young women with hair, but long, flowy, full, beautiful hair. Whereas, we can have and think of men who are bald, who are still attractive, right? We have Vin Diesel, Tyson Beckford, Bruce Willis back in the day, Michael Jordan, right? These men are considered attractive, even though they don't have hair, not so for women. And so when we had the statistic from when I was at Mass General Hospital, and it holds true today, 81% of our new patient consultations are female. And there's a lot less cultural acceptance for females to have hair loss than males. Now, this is not to take away from the fact that men can have significant issues when they start losing their hair, especially with the scarring hair loss. But there is also much less cultural acceptance for women dealing with hair loss. And even BuzzFeed says, believe us, bald men are where it's at, right? These cultural messages are being sent to us all the time, increasingly making it difficult when you're a patient dealing with alopecia. And there are certainly some women who are bucking this trend, right? We have our first bald Sports Illustrated swimsuit model in Massachusetts. Our Congresswoman Ayanna Pressley proudly goes around bald. But by and large, I would say in my experience, this is a minority of patients who are dealing with various types of alopecia. It's very, very hard. So I want to start with this just so that you take a deep breath and know, you're not alone and you're not wrong for feeling the way you do. And it's okay to feel mad or sad or scared or nervous or just really not feeling like yourself, because hair is really important. So the other important key point that I want to share from the outset is that the vast majority of patients who I see have more than one type of hair loss. Why is that? Because there are many common causes of hair loss in women and also men, okay? And these can affect men just as much. Telogen effluvium, which is an overshedding thing that occurs. We'll talk about that in a minute. It can happen when a trigger or a stressor occurs, significant illness, especially with fever, weight loss, even if it's slow and planned, intentional, okay? Significant emotional stress, like loss of a loved one, a big move, a divorce, hormonal changes, entering menopause, stopping hormone replacement therapy. These can lead to increased shedding for 3 months. And if you don't know what's telogen effluvium, you will automatically think, understandably, that your FFA or LPP is getting worse. So we're going to talk about that in a minute. Other causes of hair loss in men and women: a reduced growth phase of the hair cycle, or put simply, plain old regular male and female pattern hair thinning, right? Which all of us to some degree develop. I'm 47. I don't have the same density of hair I had at 27 or 37. And particularly after menopause or in men after the age of 50, we know the numbers of people experiencing hair thinning increase, and that's from a reduced phase of the hair cycle. Most patients who come into my hair loss clinic will also have male or female pattern hair thinning in addition to their LPP and FFA. We want to treat that as well, and I'll show you why that's important in a minute. And then, of course, we have immune cell targeting of the hair follicle. Alopecia areata is the really common one. And of course, we have the scarring alopecias, which we're focusing on tonight, like lichen planopilaris, frontal fibrosing alopecia, okay? So important to know, just because you have LPP or FFA doesn't mean you can develop a telogen effluvium, or you can also have a concomitant female pattern. Very important. So telogen effluvium, just very briefly, there are 3 phases in general of the hair follicle cycle. The growth phase, anagen. At any given time, 90% of our scalp hair should be in this phase, and they should stay growing for about 3 years until they go into a resting phase for 3 months, and then they shed, and the whole cycle starts over again. But the hair follicle is very sensitive to changes in some individuals. And so if there's a major trigger, loss of a loved one, stopping hormone replacement therapy, weight loss, and usually 7 to 10 pounds or more, 3 months later, right? Because the body says, what's going on? Takes a bunch of hairs with the weight loss. Say, let's use that example. I lose 10 pounds. My hair follicle say, what's going on? We have to conserve energy. Prematurely throws a bunch of hairs that should stay in the growth phase into the resting phase. And 3 months later, you are shedding like 300 hairs a day. Now, if I have LPP and this is happening to me, I of course think I'm having an LPP flare and that I'm going to be bald. When in fact, it is temporary, self-resolving, and the hair grows back on its own, and it has nothing to do with LPP. And most people don't recognize the trigger, what caused the hair shedding, because of the 3-month delay in when the shedding starts. In our clinic, the most common causes were significant life stress, so loss of a job, loss of a loved one, divorce, things like that. Weight loss was a big one, especially stopping hormone medications. This includes birth control or IUD or switching. Adjustments of thyroid medication, a huge thing. So yeah, they tweaked my thyroid medication 3 months ago and now my hair is all shedding. That's a very common one. COVID-19 infection has been a big one. And then some other less common causes, okay? But those can include flares of underlying autoimmune conditions like rheumatoid arthritis, lupus, things like that for people who have these. And it's really profound. So this is a patient who came in to me who said, my hair is falling out. And we got the history, and this was her when she presented 5 months after her husband's death, and I need to treat it, and I don't know what's going on. I'm going to be bald. And I said, you don't have to do anything. I think this is related to your husband's unfortunate, tragic death. Why don't you come back? We'll compare the photos. And lo and behold, it completely self-resolved. And even in patients with LPP, the hair will regrow from telogen effluvium. Okay, it has nothing to do with inflammation. So very important to be aware of it. This is a terrible picture of me after my telogen effluvium. And this is just to show how much hair you can lose. So this is 1 full year of hair regrowth. These are not bangs. This is all hair I lost that regrew for 1 year. So the other important thing to note is that it can affect preferentially the temples and frontal hairline, which can be particularly worrisome for people with FFA, but also it takes a long time to regrow. Once it starts to regrow, 1 centimeter a month. So important to keep in mind, especially if you're worried that you're in a flare. Okay, so we're going to discuss treatment goals in scarring alopecia, describe the types of inflammation involved and how I think about treatment, and review my approach to treating scarring alopecia. And I highlight my approach because medicine is an art. We can approach things and problem solve in different ways. This is my approach. It's what I have found to be helpful in my patients in almost now 12 years of seeing predominantly scarring alopecia patients. But there might be people who practice differently, and I don't want to take away from that. This is my personal preference. So as we know, these red dots here indicate inflammatory cells that for unclear reasons like to hover at the hair follicle under the skin at the level of the bulge, which is important because it's where our stem cells for the hair follicle live, right? So the reason why we grow a hair, shed a hair, grow a new hair, shed a hair is because when we are getting ready to shed a hair, the stem cells in that bulge region say, oh, time to go and make a new hair again. And over time with FFA and LPP and the scarring alopecias, that inflammation can kill off the stem cells. And when that happens, you don't have a hair follicle unit anymore. And no matter what you do, you can't regrow a hair. However, things happen on a spectrum. So sorry, I don't know why my clicker is not really working here. So we can have, so there can be early FFA or LPP, where you have a hair in place, the hair follicle unit is patent, you do have inflammation, and you may have symptoms. Not everyone does. That goes on without treatment a little too long, the hair will likely fall out, but your hair follicle unit will still be patent, you will still have inflammation, and you may or may not have symptoms. And then the end stage, of course, is when the inflammation goes on too long. You have no hair, you have no hair follicle unit or stem cells. You may have inflammation, sometimes it's burnt out, right? And you may or may not have symptoms. And that's the progression. And any hair on your head at any given time is somewhere along this spectrum. And our goal is to get that follicular rescue, right? So that you catch those areas where there may not be hair, but the follicular unit is patent. You reduce the inflammation to allow the inflammation to go away and allow the hair to regrow. And we can successfully do that with treatment. So just because you lose a hair does not mean that it's gone forever. If you catch it quickly enough and you treat it, there can be follicular rescue. And we know that with scarring alopecia, with LPP and FFA, it's these T cells or lymphocytes that are the primary, we think, effector cell, the primary inflammatory cell. There are other forms of scarring alopecia where neutrophils, a different type of white blood cell, are predominantly involved, okay? And so that's important when we think about what treatments we're going to use. So that's just more on that. There can also be some neurogenic inflammation. So this is inflammation that originates from the nerves in the skin. And this I think of as being likely present in people who have a high degree of itch or especially burning associated with their scarring alopecia. And that also is going to be important when we talk about treatments, okay? Now, the things that we do in our clinic to try to help our patients is to have specific standardized approach to patients so that we're grading them appropriately and we're documenting things so that we can follow patients with as much data as possible over time. So we ask patients on a scale of 0 to 10, how is your itch, pain, burning? And we write that down in the note. We also will mark, what is the degree of their perifollicular, meaning the redness that's hugging the hair follicle, or perifollicular scale, the scale that's hugging the hair follicle. How obvious is it? And then how much of each scalp section is affected by it? And then we measure the hairline, which is particularly important in FFA. And we measure from the lateral edge of the right eye, the mid-brow or the mid-brow bone in patients who are missing eyebrows, the lower glabella, the left mid-brow or mid-brow bone, and then the left lateral eye. And we keep tabs on these measurements over time too, to be able to determine, is the hairline moving back? Is it improving? Is it stable, or what's happening? And if we don't have photographs, then I would have had to quit my job a good decade ago, because without photographs, it's very difficult to be able to determine how a patient is doing, right? And so for FFA patients, we'll sometimes get this frontal hairline in addition to the measurements, but to get a sense of the overall density and how someone's doing, we'll also get a top-down photo. And patients will come in all the time. This was a patient of mine with FFA, I can't tell if I'm better. And I say, you are better. Right? And how much does that help? That's more than any measurement or anything else I could say to them and try to convince them of. The pictures really do speak 1,000 words. Okay, so the biggest thing I want to say first, before I get into treatment, is how important it is to avoid atrophy. Okay. So the treatment ladder for me for first line or mild disease, or in all patients, and we're going to get into anything that has a star into more detail, avoidance of potentially harmful ingredients in personal care products. We're going to talk about what those are and why in a minute. A topical anti-inflammatory 2 to 3 times per week, never more. And this is very important. As you can see on the right, different areas of the scalp have different thickness to the skin. And the anterior scalp is thinner than the top of the scalp and the sides of the scalp. And that's important because if you're putting a topical steroid or doing repeated injections on the frontal hairline and eyebrows, you're going to be at increased risk of atrophy, meaning skin thinning, loss of the fat in the skin. And when that happens, not only does it visually not look good, but also when you don't have enough fat in the skin, you cannot grow hair, even if your hair can grow. So that's incredibly important. So for the frontal hairline and eyebrows, I am always using tacrolimus solution or pimecrolimus cream because they're non-steroidal anti-inflammatories that work just as well as steroids without the steroid effects. For the other areas of the scalp, I'll usually use a fluocinolone 0.5% solution, or some people will recommend clobetasol solution. They're very similar, but you really want to limit that use to the top of the scalp, not the frontal scalp. And injections, I use very rarely and with a lot of caution. So I think of injections as sort of a fire extinguisher, okay, for patients. And I'm going to show you now why. This is a patient who came to me with LPP who had injections all over the scalp. Okay, these were fully dented areas. And I said, and on top of injections, they were putting topicals on top as well. If you're getting injections, those injections, that steroid's working for 4 to 6 weeks. You don't need to be putting topical steroids on top of that. That can set you up for atrophy as well. And all I said was, please stop the steroid injections. Please stop the steroids and just come back so you can see what's going on. And you can see here that the atrophy improved, and actually in some areas, there's regrowth because that fat started coming back into the scalp. Very, very important. Another example here of a man who came in with LPP, injections. You can get significant background redness because of this dilation of the blood vessels in the scalp from too much steroid use too. He said, but I'm red, they keep injecting me. I said, stop the steroids. We use tacrolimus solution, and you can see not only did the redness improve, not only did this denting really improve, but he got some more hair to grow back because that fat was able to come back in the skin. Incredibly important. And another patient here who kept saying, I'm flaring. I said, this is all steroids, and you discontinue the steroids and things improve. And if you look, instead of seeing red dots that hug where the hair fall comes out of the scalp, we see these dilated blood vessels everywhere. And so you know that it's telangiectasia, or that redness from the broken blood vessels, as opposed to LPP or FFA inflammation. Super duper important. And so if you absolutely need to have injections, I would do these every 3 to 6 months only as needed. For the frontal hairline and eyebrows, the concentration should be 2.5 milligrams per ml, never higher, because that puts you at increased risk of atrophy. For other areas of the scalp, 5 milligrams per ml and never higher. And basically, if this is a circle, a given area of the scalp, you want to be injecting about 0.1 ml every centimeter or so. You don't want to be pushing a big depot into one small area. That can also cause atrophy. And again, you don't need to be using topical steroids for the 4 to 6 weeks after you have injections, if you have them. That's just total overkill and sets you up for atrophy. Now, environmental factors. Why do I talk about avoiding certain ingredients? Well, particularly with FFA, this was first described in 6 postmenopausal women in 1994, and it was rare during the 90s. But particularly over the last 10 and even 20 years, it's almost like an epidemic. It's huge, and this is occurring worldwide. That strongly suggests some sort of environmental factor. Okay, and we know that these conditions, although they affect men, they preferentially affect women. And increasingly, when I see men being affected, they tend to be men who are using a lot of more grooming products. Okay. These products are not regulated by the US Food and Drug Administration. And in fact, if you look at this paper here, sorry, the arrow should be a little bit further over. I apologize for that. It should be highlighting the last column with this light blue thing. But there has been an increased reporting in adverse events to hair products since 2010. This light blue last column in 2016 is complaints about hair products from consumers, okay? And when a consumer complains about a hair product, even if thousands of them complain about a hair product, the hair product company is not required by law to report that to the FDA or to other consumers. So we are not protected, okay? And that's why we have multiple class action lawsuits for hair care products, often related to formaldehyde releasers in products, but other things as well, that go often in favor of the consumers because they are causing hair products. So what's going on? Is it something toxic? Is it something allergenic? There were also studies, right, with sunscreens and moisturizers, and I know there's been a lot of debate over this, but Dr. Lim, who was past president of the American Academy of Dermatology, did a huge systematic review and meta-analysis on studies around this in frontal fibrosing alopecia, and found that sunscreen use was associated with a 2.21 times higher likelihood of FFA, and moisturizer use, because most moisturizers, if you look, contain chemical sunscreens in them, right? Almost all, you really have to look to avoid them, with basically a 2 times higher likelihood of FFA. So they concluded that, yes, there's conflicting evidence, but you combine all the evidence and there really does seem to be a signal there. So I tell my patients to avoid chemical sunscreens and just use zinc sunscreens. And we'll look at the other things that I tell my patients to do in a minute. We also conducted a patch testing study in LPP and FFA that included 42 patients. And none of these patients thought that they were allergic to anything, yet 76% of patients had positive reactions to ingredients that were in their hair care or facial products that they were using all the time. And there were no significant differences between those that affected the FFA patients with the LPP patients. But what's interesting is if you look at our study in the MGH column and you see these things, and you look at the percentages of other investigators who have done similar work in LPP and FFA across the world, and compare these numbers to the tan column, which is the best data we have on the prevalence of these allergies or reactions in the general population, people without LPP and FFA, we see that the reactions in the LPP and FFA community are much higher, right? So in the case of fragrance mix, for example, our study showed 14.3% of patients in this study having it, whereas 0.9% in the general population will have it. So again, we think that there could be certainly something to this. And in our study, we said to patients, okay, change nothing else about what you're doing for your treatment. You're going to continue on the same regimen. The only thing that we want you to do is avoid for at least 3 months the allergens the ingredients that you were identified to be sensitized to. And nearly 60% of patients, when they did that, reported a decrease in scalp itch, and 73% had a decrease in scalp perifollicular redness or inflammation. And here's an example of one of my male patients who had an allergy to I believe it was a formaldehyde releaser. And you can see here the significant improvement here with just avoidance of that. So you're welcome to take a photo of this or screenshot or whatever works for you, or I can also give it to Facho. I'm happy to share this. But this is what I give to all of my new patients. And, ideally, I recommend using fragrance-free products, avoiding formaldehyde releasers. So these are products that, the label won't say formaldehyde, but these are ingredients that release formaldehyde in the bottle over time, which can be toxic to the hair follicle. And then there are other ingredients in hair dyes and hair color. So that's step one. And I really do think that it is a piece of the puzzle, and certainly more pronounced in some patients more than others, but I have found it to have a profound impact on patients. So we talked about the first line or mild disease. For second line or moderate disease, I'll usually recommend oral hydroxychloroquine, also referred to as Plaquenil. Eczema laser therapy, I used to use the Levia narrowband, but as many of you may know, that was discontinued, unfortunately. But the eczema laser is the next closest thing that you can get in a doctor's office if they offer it. And then the low-dose oral naltrexone, oral gabapentin, and cetirizine or Zyrtec or fexofenadine, which is Allegra. Those are in brown because I only use those in patients for whom I suspect a neurogenic inflammation, right? Patients who have significant itch or burning of the scalp. Otherwise, I don't use those. So for hydroxychloroquine and Plaquenil, important to make sure that your doctor is dosing this appropriately, because if you're overdosed on it more than 5 mg per kg of your actual body weight, you can be at increased risk of a retinopathy. Also, being on tamoxifen, which women who might have a history of breast cancer could be on, and that and kidney disease actually significantly increase the retinopathy risk. The cardiac arrhythmia risk is overall very low, but can be present in patients who are on certain medications, including Lasix, azithromycin, certain high-dose antidepressants. And really is much more associated with chloroquine than hydroxychloroquine, but the retinopathy is a big issue that you need to keep on top with. I want to try to stick to time, but basically I really like the use of phototherapy when it can be covered by insurance and people have access to it, because phototherapy is used to reduce inflammation. Now, this is different than the helmets and the brushes and combs, right? That's low level laser light. We're talking about narrow band UVB light. So it's a specific wavelength of narrowband UVB, which, as you can see, penetrates to a depth where it can really help the inflammation right where we need it around that hair follicle bulge. And we think it works by reducing T cells and reducing neurogenic inflammation. And we used this device, which was the Levia, which was a fiber optic brush head where it could deliver the light right down to the scalp to make sure it got through the hair. And unfortunately, like I said, they discontinued it. Our study included 13 patients with LPP or FFA. This was the only medication they were on. They were not on any other treatments, and they treated with this device for 3 times per week for 6 months. And we saw that 77% were partial or full responders and had a measurable improvement in their LPP and FFA at the end of the 6 months. And we did publish that. These are some patients before and after treatment. You can see an improvement in their background redness and scaling here in their target areas that we followed. Like I said, excimer laser is almost identical to the Levia. And there was a study also published on 13 patients with recalcitrant or difficult to treat LPP who received excimer laser therapy. And you can see here the before and afters for that patient's scalp too. So another great option for patients who are able to get this treatment. And then lastly, for recalcitrant or severe disease, I'm really reaching for oral Janus kinase inhibitors in patients, or JAK inhibitors, and for the frontal hairline and eyebrows, topical JAK inhibitors. We just completed a topical JAK inhibitor study in FFA, and the preliminary results look very, very favorable. So that's another great option for people who have failed other things. There was this pilot study that you might have seen by Dr. Lindsay Bordone and Dr. Angela Cristiano out of Colombia that showed improvement in patients who were on oral JAK inhibitors. You can see the improvement here in their redness and hair. This is one of my own patients. You can see the significant improvement after she failed other treatments after being on a JAK inhibitor. And another patient here who had significant improvement from being on a JAK inhibitor. And importantly, we want to, and I should only have a few more slides, Hacho. I don't want to cut in too much to the questions. Tried to get a lot in a short amount of time to try to help patients know what to advocate for. So is treatment of that concomitant female and male pattern hair thinning, right? So in women, we can use oral spironolactone, 25 milligrams to 100 milligrams, once daily. In men and women, we can use low dose oral minoxidil. In women, I use 0.625 to up to 2.5. In men, you can go up even to 5 milligrams or 10 milligrams a day. The rate limiting, the dose limiting, I should say, thing with women is that there could be a mild increase in facial hair with oral minoxidil. Doesn't tend to be a big issue usually for FFA patients, but obviously less bothersome for men. If you have dandruff, cyclopirox shampoo, which is a prescription, it can be very helpful and not as drying as ketoconazole shampoo. So that's another thing. And this is just some examples of my patients who are on multiple therapies. So I showed you this patient earlier. This is after being on tacrolimus solution and spironolactone, 25 milligrams a day for 6 months. So we're treating the inflammation with the tacrolimus solution. She's also obviously avoiding allergens and doing all of that. And then we're also treating the hair density issue with spironolactone to provide more coverage of the hairs that have not been affected yet by FFA, but also those hairs that might have been affected by female pattern hair thinning to provide, again, more coverage. Here's another patient of mine before and after. This patient was on oral minoxidil, allergen avoidance, topical Lidex or fluocinolone solution twice a week. And I did do intralesional steroids for her every 3 months for 1 year because she had a lot of inflammation involved. Some patients will twist my arm and beg me to do platelet-rich plasma. It's not something that I automatically run to. It's expensive. If it was free, I would try it on everybody. But if it's $900 an injection, you need 3 injections. It's very costly. It's not covered by insurance. So, it's not the first thing I recommend, but these are some patients who said, what about PRP? And you can see, in addition to our other treatments, there can be a slight increase in the hair density from PRP as well. And like I said, scarring alopecia patients can get telogen effluvium too. So if you are suddenly shedding hair, take a deep breath and think, what happened 3 months ago? Did I lose weight? Did I have some terrible stressful event? Was my thyroid medication changed? Did I have a terrible illness? Was I hospitalized, God forbid? Did something happen, right? Because 9 times out of 10, that is the reason why you're shedding, not because your LPP or FFA is flaring. And that shedding will last for 3 months and then it will slow down. And it just will help you to sort of catch your breath and not be chasing your tail, trying to treat and treat and treat for something that just needs to run its course and self-resolve. So in summary, and I'm sorry, this was sort of a whirlwind tour towards how I treat, but you want to base the treatment approach on therapies that counteract the type of inflammation that you have. So topical steroids for the top of the scalp, topical tacrolimus for macrolimus, topical JAK inhibitors, Plaquenil, and then for those itching and light therapy, and then for those itching burning, right? That's when we start thinking about naltrexone, Zyrtec, Allegra, gabapentin, right? You want to please avoid atrophy. You need to give each treatment enough time to work. I see patients no sooner than 6 to 8 months after I initiate something, because otherwise I'm not going to be able to tell what's going on. Hair takes a long time to respond to therapies. And again, if you have scalp symptoms, you want to treat that neurogenic inflammation with the medications I mentioned. And you really want to be mindful of the ingredients and personal care products used on the head and neck. So with that, I will thank you and remind you too, the Scarring Alopecia Foundation is doing a lot of work as well. It was formerly CARF to try to help patients as well with scarring alopecia. So if you're not aware of them, in addition to the fabulous group that Hacho has on Facebook, just be aware that they exist as well. So thank you all so much. And with that, I'll stop sharing. And Hacho, I'm sorry if I went over a little bit, but I'm happy to take any questions.
That's okay, no problem. Thank you very much, Doctor, for your presentation. It was very helpful, I think. Okay, number one, I think maybe you already answered this question, but I'll ask anyway. Is there any possibility for first-line steroid injection to cause hair shedding, since shedding has worsened in the areas that has been injection?
So absolutely, as I mentioned, you're right. If there's atrophy, if there's that skin thinning, if there's dents, that can lead to hair loss, okay? But if that's not there, and it's just been one injection and there's no signs of hair thinning or denting, then you really want to start thinking, why is my hair shedding? It's probably not from the medication, and it's probably much less likely that it's the FFA or LPP. You really want to screen and say, what could have triggered a shedding episode? Did anything happen 3 months ago that triggered a shedding episode?
Makes sense. All right, the second question is, can dutasteride be injected?
There are, so I didn't, it might be glaring that I didn't mention dutasteride. I don't use dutasteride in any of my patients. Personally, and again, medicine is an art, this is my approach. I don't find that I need to reach for it. I use a lot of spironolactone. I personally like spironolactone better because there's a lot of breast cancer risk data for it. So they actually tested spironolactone in patients with breast cancer who are on it and saw that there was no increased risk of new breast cancer or recurrence of breast cancer, right? There's really no data for dutasteride and finasteride for breast cancer. And I think spironolactone works so well, and I just don't feel like I have to reach for dutasteride. But for dutasteride, there are patients that are physicians rather that are offering what's called mesotherapy, which is injecting the dutasteride into the skin. I don't offer that yet because I don't know what the data is and the side effect profile is. Like if you inject it, is there zero in the bloodstream? Is there some in the bloodstream? And honestly, with the therapeutic ladder that I showed, I don't find that I need to reach for it. I find that those treatments work for patients. There are some groups that are offering it, but many of us are waiting for more safety data on it.
I see. Okay. Okay. The third question says, do you believe that drugs targeting epithelial mesenchymal, is it? Transition molecules or mesenchymal epithelial transition molecules would be better than the traditional immunosuppressant to treat LPP?
So I think what this person is trying to get to, right, is Ralph Poss and has papers looking at the fact that there can be this epithelial mesenchymal transition that happens where in scarring, there's like this basically stem cell change that causes a change in sort of the surrounding tissue of the scalp and can lead to fibrosis and scarring and permanent hair loss. The problem is that, yes, while we can try to target those, they might help. A lot of the treatments that we use, like Plaquenil, we're not even 150% sure how they're going about working, right? So they might already be doing that, number one. We use them in a lot of rheumatological conditions and other potentially scarring conditions with good effect. So maybe that some of these medications already are. But the other thing is too, it will depend upon what stage, right, the certain area of the scalp is in. If it's a much earlier phase that it's not there yet at that transitional phase, well, targeting that won't necessarily help. So it depends upon the stage. And I think, we would need to have a lot more research to understand, the impacts of something like that.
I see. Okay. Have you ever used oral sirolimus or topical lovastatin or losartan to treat LPP? And if so, what was the outcome?
I have not, but I have plenty of patients, many patients who are on these medications because they have to be, right, for their blood pressure or whatever. And I haven't seen it have an impact. And in fact, when I first started Mass General, we looked at different medications like statins and blood pressure medications and things like that, and whether or not they were higher in patients who had LPP or FFA versus patients who did not, and there was no significant difference there. So I have not used these topically. Again, the therapeutic letter I went through is what I use, and I haven't seen, for example, that patients on oral losartan do better than my patients who are not on a medication like that.
Okay. All right, the next one is your thoughts on the two drugs, Oluminant and Litfulo. Is either drug helping with LPP or FFA?
Yeah, so first I want to be clear my disclosures. So I do consulting and I'm a speaker for Lilly, who is the maker of Olumiant or baricitinib, and also for Pfizer, because there's so few of us who are hair loss specialists, they call on us, who makes Litfulo or ritlecitinib. Yeah, as I showed in my presentation, the JAK inhibitors for severe patients can be incredibly helpful. The thing is that you want to be very careful because there are boxed warnings on those for those medications. When they're used in a younger sort of healthy population, like the alopecia areata population tends to be, those risks are incredibly low. However, we know, particularly over the age of 50, if patients are smokers, if they have other comorbidities, diabetes, et cetera, they really have to be used with a little bit more caution, as it can put them at increased risk of potentially more serious side effects. So it's not something that you just go on, without some thought. There has to be a good discussion with someone who understands these medications.
Actually, I missed the last portion of the question. It says, and also, does it have better results if you take oral minoxidil along with doing PRP injection treatment?
With a baricitinib or
I guess, yes.
Yeah, I mean, so it depends. So because like I said, most patients have more than one hair loss condition going on. And since the vast majority of patients that I see with LPP or FFA also have some hair thinning, almost all of my patients are also on minoxidil or spironolactone to treat that part of the hair loss for best outcomes. Now, with JAK inhibitors, if that's what the patient's getting, if this is what the person's getting to, there's some evidence to suggest that JAK inhibitor plus minoxidil works better than JAK inhibitor alone in alopecia areata. Mm-hmm. We don't have that same sort of data for the scarring alopecias, but my guess is probably it would provide some more coverage. PRP, again, I don't routinely reach for just because it's costly, so it's hard for me to comment on that.
Okay, great. All right, does muesli, M-U-S-E-L-Y, are you familiar with this? Because I know last time on my webinar also, he just wasn't sure about this. The hair topical solution, which contains minoxidil 6%, dutasteride 0.1%, tretinoin 0.01%, and ketoconazole 2% helps FFA.
I don't use it. I mean, here's the thing. I don't know how much it costs. There are a lot of gimmicky products online with these combination therapies and blah, blah, blah. The problem is when you're putting something topical like that on your scalp, especially with the retinoid in it, that can be very irritating to the scalp. And in an inflammatory hair loss condition, I worry about that triggering underlying inflammation. Even if there's not an allergy, it could be an irritant contact dermatitis or something that it could trigger. And because the side effect profile and the cost of oral low-dose minoxidil is so favorable, I reach for those before any topical thing like that. Yeah.
Okay. So I wonder if this is muesli is a prescription or just the
It looks like it's just like a online, I don't know, with a
I
link
see.
to it. It's like a prescription skincare kind of group, but I
Okay.
mean, I don't routinely use those types of things for patients with scarring
I
alopecia.
hear you. I hear you. How do other autoimmune diseases affect LPP?
So it depends.
Mhm.
We looked at, when we did that study looking at people with LPP and FFA and people who don't have that, and we looked at thousands of patient charts at Mass General, there was no significant difference in systemic things with LPP and FFA. We looked at cardiovascular disease. We looked at cancers. We looked at rheumatoid conditions. We looked at inflammatory bowel disease. We looked at every autoimmune disease you could think of. And we did not see any statistically significant increases in the patients who had LPP and FFA. That being said, that doesn't mean that when an individual patient has one autoimmune condition, they might not be more prone to another autoimmune condition, okay? So that can happen, certainly. And as I mentioned when I was talking about telogen effluvium, that overshedding flares in underlying autoimmune conditions. So say you have Crohn's colitis and you have LPP and FFA, and you go through a huge flare in your Crohn's colitis, and you require medication adjustments, and you feel unwell, blah, blah, blah. 3 months later, you could have a huge shed of your hair because of that flare, which can make you think your FFA and LPP is flaring, which it is not. But also, there are some patients who will say, I noticed my LPP or FFA flaring with that underlying disease. I can't say that happens for everyone. There are patients who will notice that sometimes.
Maybe I think here is more like a thyroid condition, perhaps. Is that also considered?
So again, thyroid condition, I don't think of as flaring inflammation.
Mhm.
Okay, there are two separate things. Thyroid flare or adjustments in thyroid medication can disrupt the hair follicle cycle and cause periods of overshedding. But it does not cause an increase in inflammation. That's very different.
Which is not a scarring, yeah. Mhm.
Correct.
Okay.
And that's it's self-resolving, it's short-lived, it's a lot of hair that can be shed, but it's not related to the inflammation and scarring with LPP and FFA.
Okay. All right, the next question. I would like to know what the latest research says about the effect of LDN on LPP. Maybe you touched on it.
Low-dose naltrexone. There's not a lot of research for low-dose naltrexone and LPP. I don't really prescribe it very much. If I'm going to treat neurogenic inflammation, I most commonly use gabapentin because it works incredibly well, and it's much more cost-effective for patients. It doesn't cause GI upset like naltrexone can cause in some patients. So there's not a whole lot of research that I'm aware of that's done on a larger scale, like a placebo-controlled type scale. But in my experience, I find that gabapentin can work quite well for the neurogenic itch inflammation.
Great. Okay, can you please discuss the phenomenon of COVID hair and review the potential danger with autoimmune conditions and vaccines so members are aware and can discuss the pros and cons with their providers?
So again, there's some research on this, not a ton. What I would say is this: many people get COVID. So for COVID hair, I find that it can lead to, again, telogen effluvium, where the COVID either infects the hair follicle, leading to the hair shedding several months or 3 months later, or a person is so ill that 3 months later, 2 months later, it triggers a telogen effluvium and overshedding. Again, not related to the inflammation of LPP and FFA, but a secondary hair loss on top of that can make it feel like a flare, okay? When does that happen? It doesn't happen with every COVID infection. It tends to happen, in my experience, in patients who have COVID infection and are sick. They have fever, they're in bed, they don't feel well. Or patients who have COVID vaccination and feel very unwell afterwards, right? It's not in patients who just get the vaccine and go about their business, or just get COVID and they didn't even know they had COVID. That doesn't tend to happen.
All right. How do you tell the difference between MBP and LPP? Can LPP mirror the hair loss pattern of MPB? I guess.
So this patient, just for people watching, I think they mean male pattern baldness.
Yeah.
So there's a condition called fibrosing alopecia in a pattern distribution. If I had more time, I would show you examples of this too. Basically, more or less, and I'm not going to go into the details here, even though there are details that can separate the two on biopsy. Okay, but more or less, I approach treating them the same way.
Oh, you do.
And when you look at a patient, there can be subtle changes on the biopsy that can be a little bit different, but more or less the clinical signs and symptoms seem to be similar. Perifollicular scale, perifollicular redness, and you have to have, as a physician, a very high degree of suspicion for these, because patients will present as having female pattern hair loss or male pattern hair loss. Right? It won't be patches or vert scarring. It will look like just thinning. And so you have to get your magnification and really look closely at the scalp through trichoscopy to say, there are signs here, okay, of scarring alopecia, and do the biopsy to confirm it. Once it's diagnosed, right, then my approach is to treat it very similar to how I discussed treating LPP and FFA.
All right. The next one, are JAK inhibitors the best treatment option for scarring alopecia?
So hopefully my presentation covered some of that too. Again, topical JAK inhibitors can be safely used in patients of all ages, comorbidities, et cetera, and can work quite well in FFA. For oral JAK inhibitors, they can be considered in patients who have failed everything else, who are, with proper screening. So you have to make sure that the patient is not at high risk of things like heart attack, stroke, blood clots, things like that, serious infections. So you need to screen appropriately. But yes, in a select patient group, they can be very helpful in recalcitrant cases.
Okay, have you seen any benefit in using topical or oral metformin or LPP?
I have not used it in LPP. I have a few patients with CCCA where I have used it. Similar to the losartan question, I have to say I have a lot of patients who are on metformin orally, systemically, for their prediabetes or diabetes. And I have not seen, for example, that those patients do so much better than my patients not on it. I think we need a lot more research. I know Crystal Agu's group out of Johns Hopkins, I believe, is working on some more data for that in the CCCA, so centrifugal cicatricial alopecia population. But I don't know that data right now. It can be helpful in some patients with CCCA.
I see. Okay. The next one, how often should hair be washed, and any recommended product to use? Is it okay to use styling hair gel?
Yep. So again, you want to look for products that don't contain the ingredients that I shared earlier. As far as how frequently to wash, that depends upon how frequently a patient's hair feels like it needs to be washed. There are some patients who only need to wash their hair once or twice a week. There are some patients who really feel like they have to wash their hair every day. I would say the average patient probably needs to wash their hair 2 to 3 times a week. Now, my patients who are Black, who have different texture hair, washing their hair 2 to 3 times a week is ridiculous. It would completely over dry their hair. And so they can wash less frequently. But I'd say on average, all patients taken together, it's somewhere around 2 to 3 times a week typically. And so, but you base that on what you need to do. The fragrance-free SEEN, SEEN products are very good because they don't contain the ingredients. We did a study for them in LPP and FFA, and they seem to help with the inflammation. They don't contain any of the ingredients. They are color safe, know nothing products. Many of my patients like and use, but again, sticking to avoiding ingredients on the list that I showed earlier, you could expand upon that list, certainly.
I think this question is more or less for the LPP or FFA patient, whether they should do less washing or more washing, I guess.
I think it does not matter. It's not like washing more frequently is going to somehow trigger your disease. I do think that when you wash, most people with hair loss understandably are very gentle with their scalp. That's not always the right thing to do though. You want to get your fingertips and you want to massage the scalp to get off the debris and get off any topical medication, residue that you're using. Because if you're not doing that, I do worry about that buildup further contributing to the inflammation.
I see.
You want to make sure that you're thoroughly cleansing. But again, I think most patients with LPP or FFA, somewhere around 2 to 3 times a week on average, I think is likely
Okay.
what makes sense.
Wonderful. Okay, the next one. What is the general experience with the disease burning out? After what time on average do they see people go into remission? And how many really burnout? Is the number of around 50% of the cases burning out within 2 years still accurate?
So my patients, I say to them, here's what we're going to do. At the beginning, we're going to hit this hard. We're going to get the inflammation under control. We're going to do the things that we talked about in the talk. Once you're under good control, you're avoiding potential harmful ingredients, et cetera, and you're under good control for a while, we're going to scale back and put you on a maintenance regimen. In my experience of 12 years, and again, I see so many LPP and FFA patients, it is incredibly rare that someone just burns out and never has to think about it again. And I know that's going to be bad news for a lot of people, and people are going to say, oh, crud. But we try to get them on something so that you're putting a topical in 2 nights a week at bedtime, and you're washing it out in the morning, and it works for your life, and it's keeping the inflammation at bay. And we can do that successfully. I think of it more as sort of a chronic condition, and I treat it that way. I think that patients can go into remission and then flare again. Whereas if they're on a maintenance therapy, they're less likely to have those ups and downs. And that's when I worry about potential for more hair loss, right? Also, for patients who, sorry, I'm losing my train of thought with what I was just also going to say. We're saying oh God, I just lost my train of thought.
You can go to the next question.
What was the end of part of that question? I just want to make sure.
The vitamins and hair products that they newly diagnosed LPP, for the newly diagnosed ones.
I don't give people vitamins and things like that. It's all gimmicky. Yeah, and actually a lot of people ask about Nutrafol too. I think Nutrafol is like a class action lawsuit against it now. I just tell people there are a couple of things. We make sure vitamin D is optimized. We make sure hemoglobin A1C, right, for patients who might have had prediabetes or diabetes, is optimized. We make sure the ferritin, which is a marker of iron deficiency, is above 40. But outside of that, I'm not telling people to do supplements and everything. I just don't find them to be very helpful.
Okay. The next question is a little bit long. Online, we see a limitless number of diet and lifestyle related suggestions for ways to combat general or localized inflammation or autoimmune disorders such as LPP. Suggestions range from carnivore diets to give vegan raw food diets to extended water fast and cold showers or ice plunges to sauna and everything in between. Do you, as a medical professional, have you any suggestion that you actually recommend to patients as things they can or should try to implement alongside the modern allopathic treatment tools that evidence-based medical training has put on your disposal?
So, number one, there's a lot of weird things on the internet and stuff like that. That being said, I do tend to practice holistically, and I think about the person sitting in front of me. If you are not eating well, if you are not sleeping, if you have completely unmanaged depression or anxiety, if you are eating certain food groups that make you feel lousy, you have bloating, you have gas, you have bowel changes in your bowel movements like diarrhea, constipation, you need to listen to your body and give your body what it needs, okay? However, dunking yourself in a cold bath or ice thing, driving yourself crazy with restricting certain things in your diet without paying attention to those signs and symptoms of what it might be for you is creating more anxiety without any real benefit or outcome. The one thing I will say is I think that as a nation, we have a real microbiome problem where our gut health is really off. And that is particularly pronounced in patients who tend to routinely drink moderately or heavily, right? And that's a lot of Americans, and especially if they're in the setting of poor diet. So I say to my patients, if there is something specific that you eat that you know always makes you feel terrible, I would probably avoid that. If there's something you have a known allergy to, obviously, I would avoid that, right? If you are having persistent GI issues without a real cause, it could be that something with the microbiome is off. And if you want to use something like a daily probiotic, that would be a helpful thing to do. And the refrigerated probiotics would be the ones of choice. They tend to be the most effective and work the best. Outside of that, though, there is no compelling evidence for any of the things, unfortunately, particularly in scarring alopecias. But also, if a patient does one of these things and feels so much better and sees a big improvement in themselves, great. That's wonderful. I'm not telling you not to do it, but to sit here and say that there's like significant evidence that it helps or that everyone should go do this, that unfortunately does not exist.
All right, so we have one last question. I know we have lots of questions on this meeting, but I don't think we'll have time because we're just about to hit 6 o'clock. So, okay, is LPP associated with ear eczema? Is a possible eczema brought on by LPP?
So a lot of patients with LPP will have also scalp psoriasis, which can affect the ears and sometimes just the scalp. But also when I hear the word eczema, I think contact dermatitis, allergic dermatitis, which especially if it's the outside or behind the ears, that's a common cause, right, for dermatitis in those areas from, again, personal care products can be a big culprit. And so, you know, it's hard to say without being able to see what it looks like, because if it is actually eczema or contact dermatitis, if it is psoriasis, and if there's evidence of psoriasis on the scalp, but it is important to treat those, because I don't think it's just like a random event that you have both of these things going on. There's probably something triggering the ear reaction that's related to what's triggering the inflammation in the scalp. So I would pay attention to that.
Okay, so it's about 6:03. What do you think? So,
yeah, I really feel like it was a pleasure. I hope that what we discussed was helpful for everybody.
well, thank you, really thank you for this. I know you have on your busy schedule to give us an hour for us. I really do appreciate it.
It's my pleasure. And I typically would stay on longer, but I have an 8-year-old downstairs who's sitting down there by herself because my mother-in-law is sick tonight. So otherwise I would normally stay on longer to answer questions, but hopefully people will find this helpful. And thank you again, Hacho, for all you do.
Oh, you're welcome. I thank you, doctor, for your time and for your dedication, especially for scarring alopecia.
Of course. Lovely to be with you.
Thank you very much.
Okay, bye-bye.
Bye-bye.